All right, welcome to another deep dive. We love to take those listener requests, and this one's a doozy.
Oh, it's a good one.
This one is fascinating. We're talking about neurorespiratory disorders,
Yeah,
specifically how stuff going wrong in your nervous system
right.
can end up having a huge impact on your breathing.
Absolutely.
And we're looking at medical textbook excerpts for this one,
Mm-hmm.
primarily chapters 29,
Okay.
30, and 31,
All right.
which really go deep
Yeah.
into this whole interaction.
Yeah, it's fascinating.
So whether you're, a healthcare professional or just someone who's
Mm-hmm.
curious about the human body,
Right.
this deep dive is for you because it's pretty incredible how
Yeah.
these two systems are connected.
Yeah, a lot of people don't realize just how much our ability to breathe actually relies on a healthy nervous system.
Absolutely.
It's so important.
Like we take breathing for granted, and
We do.
We really do.
And when something goes wrong, it's
You realize how fragile it all is.
absolutely.
So let's jump right in. Let's start with something called
Mm.
Guillain-Barré syndrome.
Okay.
You've probably heard of this,
Mhm.
GBS. And what's wild is this disorder can actually cause rapid onset paralysis.
Yeah.
I mean, can you imagine waking up
It's scary.
one morning and not being able to move?
Yeah, it's a scary thought for sure. And it's a reality for many people who
Right.
are diagnosed with GBS. It's categorized as an autoimmune disorder
Okay.
where your body's immune system
Right.
is mistakenly attacking the peripheral nerves,
Oh, wow.
which are responsible for, transmitting those
So
signals
it's attacking
between your brain and muscle.
your own body.
Exactly.
That's wild.
So when those nerves are under attack, they can't, function properly.
Right.
And that's what leads to the weakness, the loss of reflexes, and, in severe cases, even paralysis.
Oh, wow.
And then looking further into it, the source material goes on to describe
Oh.
some pretty significant anatomical alterations in the respiratory system, too.
Really?
Like there can be this mucus buildup, blocked airways, even something called atelectasis,
Atelectasis.
which a lot of people probably haven't heard of.
Well, I mean, I've heard of it, but I couldn't tell you exactly what it is.
Yeah, so it's basically a collapse of those tiny air sacs in your
Oh,
lungs,
wow.
which we call alveoli.
Okay.
And that makes it, really difficult to get that oxygen
Right.
into the bloodstream. And that's why it's so important to closely monitor lung function
Right.
for anybody with GBS. Healthcare providers often measure things like
Okay.
forced vital capacity, maximum inspiratory pressure, maximum expiratory pressure,
They're trying to see how strong those breathing muscles.
exactly.
Okay.
How strong they are, how well your lungs are functioning overall.
I got it.
Yeah.
So, and then the treatment for this, it sounds like it's kind of all over the place. They talk about plasmapheresis and intravenous immune globulin, which
Right.
sound pretty intense.
Intense, yeah.
And then they even just mention NSAIDs for pain.
Yeah.
So it's like a whole...
Yeah, it really depends on the severity. But the overall goal is really to support that respiratory system
Right.
as much as possible while the body kind of,
While it's healing.
recovers and heals. Yeah. So that could mean anything from providing oxygen therapy, using techniques to help clear the airways,
Okay.
to, even in severe cases, needing mechanical ventilation.
Wow. So that's a huge range of intervention.
Big range, yeah.
So we've talked about how nerve damage can actually impact breathing with GBS.
Right.
But let's look at something where it's not the nerves themselves,
Okay.
but the communication between the nerves and the muscles.
Okay.
And that's where myasthenia gravis comes in, MG.
Yes.
This is a chronic,
Right.
a neuromuscular disorder, and it basically messes with how this crucial neurotransmitter called acetylcholine, AC, does its job.
Yeah.
And AC, that's kind of a big deal, right?
Oh, it is a big deal. It's essential for muscle function throughout the body.
Right.
So in MG, that transmission of ACH is disrupted,
Got it.
and that can lead to muscle weakness that can kind of fluctuate.
So it's
That's a
not
day.
constantly weak.
Not constantly, no. It can vary.
Interesting.
So someone might be strong in the morning
Okay.
and then weaker in the evening.
Wow.
And that's actually one of the things that makes MG so difficult
Okay.
to diagnose,
Okay.
because people might go for weeks, or
Right.
even months, feeling completely fine,
Right.
and then, all of a sudden they're experiencing weakness
That's going to be tough.
in certain muscles, particularly like the eye muscles.
To not know what's going on.
It's very frustrating.
Yeah. So they talk about two types of MG,
Right.
right? You've got the croccular,
Mhm.
which affects the eye muscles, and then you've got the generalized.
Yeah.
So generalized is obviously a broader range.
Affects more muscles, yeah.
And then they go on to say that in severe cases, you can actually have something called a myasthenic crisis.
Yeah.
What is that?
So a myasthenic crisis is a life-threatening situation.
Okay.
It's where the muscles that are involved in breathing
So it's not just your
become
arms.
so
Right.
weak that a person can't breathe on their own.
Oh, wow.
So, this happens because the diaphragm, that main muscle we use for breathing, is affected.
Okay.
So it can be very serious.
So what causes this breakdown in communication,
Right.
between the nerves and muscles in the first place?
So it really comes down to antibodies.
Okay.
So in MG, the body is producing antibodies
Got it.
that disrupt the transmission of acetylcholine.
Okay.
And these antibodies, they can block AC
Okay.
from reaching its receptors on the muscle cells.
So it's like blocking the signal?
Exactly. They can, speed up its breakdown
Oh, wow.
or even destroy those receptor sites.
Wow.
So it's kind of like a multi-pronged attack
That's wild.
on that communication system.
Yeah, the source material says between 36,000 and 60,000 people in
Yeah.
the U.S. are living with this.
That's a lot.
Yeah. And females, typically between 15 and 35, are diagnosed. And then for males, between 40 and 70.
Interesting.
But given how, you said it fluctuates,
Yeah.
how do you even diagnose this?
Yeah, it's tricky. It takes some protective work.
Uh-huh.
But it really starts with, carefully reviewing the patient's medical history,
Okay.
their symptoms. But, doctors might also conduct a range of tests.
Like what?
So there are bedside tests, immunological studies, and then electrodiagnostic studies, which are a little bit more involved.
So what are some of the signs that somebody might have this?
So one of the main ones is chronic muscle fatigue. So imagine feeling like you've just run a marathon, but you've barely moved.
Right.
So that's that extreme fatigue. You can also have progressive muscle weakness.
Okay.
That gets worse with activity and then improves with rest.
Okay.
And then, of course, facial muscle weakness is common.
Yeah.
And so that can manifest as drooping eyelids, double vision, even paralysis of those eye muscles.
Oh, wow. So we're not talking about
Right.
weightlifting kind of weakness. We're talking about it can affect keeping your eyes open.
Yeah, even those simple tasks.
That's wild.
Yeah.
So how does this muscle weakness then affect someone's daily life?
Well, imagine struggling to catch your breath.
Yeah.
Slurring your words, or even having food go down the wrong pipe.
Right.
It's also common to experience difficulty walking
Okay.
with like an unsteady gait. Weakness in the arms, the hands, fingers, legs, neck.
Okay.
Really, it can affect any muscle. And, what's really interesting is that the source material points out that the early stages of MG can actually be quite subtle.
Really?
So some people might experience normal health
for a while.
for extended periods.
Wow.
Before any weakness sets in.
That makes diagnosis even harder, I bet.
Yeah, it can be quite challenging. Someone might feel completely healthy for months.
Right.
And then all of a sudden experience weakness, later in the day.
Wow.
Or in the evening.
That's wild.
Yeah. It's like their energy reserves are just completely depleted by the end of the day.
Oh, okay.
Yeah.
So how do doctors even test for this?
So there are a couple of interesting tests.
Okay.
One is called the ice pack test.
Ice pack test?
Yeah. So they actually place a bag of ice over the eyelids
What?
for a few minutes to see if it temporarily improves.
See if it helps with the drooping.
There's also the edrophonium test or tensilon test.
Okay.
Where they inject a medication to block the breakdown of acetylcholine.
Okay.
And if muscle strength improves after that injection, that could be an indicator of MG.
Okay. So they're looking for those little clues.
Exactly.
So what about managing it? What kind of treatments are available?
So the first step is really to assess how well that diaphragm's functioning.
Right.
Doctors will often measure, those things we talked about before, the forced vital capacity,
right.
Maximum inspiratory pressure, maximum expiratory pressure to get a sense of its strength.
Okay.
And then there are medications like pyridostigmine, also known as Mestinon, that can help improve muscle strength by increasing the availability of acetylcholine.
Okay.
Yeah. And then you've got...
What about all those other, chronic immunotherapies and rapid immunotherapies, those big names, like glucocorticoids, azathioprine, mycophenolate mofetil.
Yeah, those are about...
cyclosporine, those are all in there.
Yeah, those are the heavy hitters.
Yeah.
So those medications, they work by suppressing the immune system.
Okay.
To reduce the production of those, harmful antibodies that are attacking the acetylcholine receptors.
Okay.
And, sometimes they use rapid immunotherapies.
Okay.
Things like plasmapheresis and intravenous immunoglobulin.
Yeah, those are in there.
Might be used to quickly remove those antibodies from the bloodstream.
Okay.
And then for some people, thymectomy, which is surgical removal of the thymus gland, might be recommended.
Okay. So it's a pretty multifaceted approach to treating this.
It is.
And I'm sure respiratory therapists,
absolutely,
just like with GBS, play a key role.
They're essential. They're essential in monitoring lung function. Teaching patients those techniques to clear their airways and cough effectively.
Yeah.
And, managing that ventilatory failure if it occurs.
Right.
They're really the unsung heroes.
Yeah. So we've talked about GBS and MG, which directly affect the nerves and the muscles involved in breathing. But what happens when it's the spinal cord itself that's damaged? We'll get into that after a quick break. We'll be right back.
Sounds good.
So spinal cord injuries, SCIs, it's a topic that, can affect anyone.
Yeah, absolutely. And the impact of an SCI could be really significant.
Life-changing.
Yeah, life-changing. And breathing is often one of those immediate concerns.
Yeah, that's what they talk about in here. They say there are approximately 288,000 individuals living with an SCI in the U.S. right now.
Wow.
And about 18,000 new cases every year.
Yeah, it's more common than people realize.
And that doesn't even count the people who, sadly die from it.
Right.
At the scene.
It's a serious injury.
Yeah, and they're talking about, the causes are things that we encounter all the time. Motor vehicle accidents, falls, sports injuries. And interestingly, about 78% of new SCI cases are male.
That's interesting. I wonder why that is.
Yeah, that's a whole other deep dive right there.
Right.
But let's focus on how the location of that injury on the spinal cord actually affects breathing. We hear about paralysis, but what's the connection to the respiratory system? Right.
So it really depends on where that injury occurs along the spinal cord.
Okay.
So injuries to the lower part of the spine, what we call lumbosacral injuries.
Okay.
Those might lead to, weakness or paralysis in the legs. You might see muscle spasms.
Okay.
Problems with bowel and bladder control.
Okay, so what about if it's higher up?
Yeah, so higher up on the spinal cord, closer to the neck, that's when things get really critical.
Especially like, the neck area.
Yeah, the cervical nerves.
Okay.
And specifically, we're talking about nerves C3, C4, and C5.
Okay.
Those are the ones responsible for sending signals to the diaphragm.
Right.
That big dome-shaped muscle that's essential for breathing.
Right. So if those are damaged.
Yeah, so if those are damaged, the diaphragm might not be getting those signals.
It can't work properly.
It needs to contract and relax.
Right.
Yeah. So any injury at or above this level can cause serious breathing problems.
Right.
And it requires immediate medical attention.
And it's not just the diaphragm that can be affected.
No, you're right.
They mentioned thoracic cord injuries. So that's like the middle part of the spine.
Right in the middle.
Can lead to problems with coughing.
Coughing, yeah. Coughing is so important for clearing the airways.
Right.
Get that mucus and any irritants out.
Right.
And then those muscles involved in coughing are weakened because of that spinal cord injury.
Oh, okay.
It becomes harder to generate a strong enough cough to keep those lungs clear.
So you can have all that mucus build up, and then that can lead to other problems.
Yeah, infections and other complications, for sure.
Yeah, it's like something we take for granted.
Yeah, totally.
Like coughing. Yeah.
Totally. We don't even think about it until we can't do it.
Yeah. And then they mentioned some other, ways that SCIs can impact the respiratory system, like rib stiffening, decreased thoracic compliance, increased abdominal compliance.
Yeah, these are all important things to understand.
And something called paradoxical breathing.
Paradoxical breathing. Yeah, that's a tricky one.
So let's break some of those down.
Okay.
So rib stiffening and decreased thoracic compliance.
Right. So those basically mean that the chest wall becomes less flexible.
Okay.
So it's harder for those lungs to expand during inhalation.
Like trying to blow up a balloon that's already been blown up.
Exactly. You're trying to get more air in, but it's a struggle.
Yeah.
And then you've got that increased abdominal compliance, which means that the abdomen's bulging outward when the diaphragm contracts.
Oh, okay.
Which actually hinders lung expansion.
I would think it would help.
Yeah, you would think so, right?
Like it's making more room.
But it actually works against it in this case.
Oh, wow.
And then, that paradoxical breathing.
Yeah.
That's where the chest wall moves inward during inhalation.
Oh, wow.
And outward during exhalation. So it's the opposite of what should be happening.
It's backwards.
Yeah, it's like the whole mechanics of breathing are reversed.
Wow. No wonder people have breathing problems.
Yeah, it's a big deal.
Yeah. And they talk about autonomic dysfunction.
Autonomic dysfunction, right. So that refers to problems with the autonomic nervous system,
Okay.
which controls things like heart rate, blood pressure, body temperature.
Okay.
So SCIs can disrupt those functions,
So it's a cascade.
leading to things like low blood pressure, sudden drops in blood pressure,
Problems.
rapid heart rate.
Yeah.
Yeah, it's like a cascade.
Yeah. So it's not just the breathing.
No, it's a whole system.
It's a whole bunch of stuff.
Absolutely.
So how do you even begin to classify these injuries?
Right. So there are two main categories,
Okay.
complete and incomplete.
Okay.
A complete SCI, that means there's no sensory or motor function below the level of the injury.
Okay.
So it's like that communication pathway is completely severed.
Got it.
An incomplete SCI,
Okay.
that means there's some degree of preserved function.
Okay.
So you might have some sensation, some movement below that injury level.
Okay.
Yeah.
So with incomplete, there's a chance some function could come back.
Yeah, exactly. And incomplete SCIs are further categorized, based on those specific patterns
Okay.
of sensory and motor function that are remaining.
So they can kind of tell what's
So it gives doctors a better understanding of, the extent of the injury.
Got it.
and the potential for recovery.
Okay. What about diagnosing it?
Okay, so diagnosing it, you're going to be using,
What kind of imaging?
imaging is key. So X-rays, CT scans, MRI,
Okay.
all essential tools
See what's going on.
for visualizing that spinal cord and determining, where the injury is, how severe it is.
Yeah. So in immediate management, I imagine stabilizing the spine is super important.
It's critical. Stabilizing, especially the cervical spine
Right.
and those cervical injuries,
To keep it from getting worse.
you want to prevent further damage. Yeah, absolutely. So that often involves immobilizing the neck, maybe with a collar,
Right.
providing manual stabilization, or even surgical intervention to realign those vertebrae.
Yeah. Sounds like time is of the essence.
Absolutely. Time is critical. The sooner you stabilize that spine,
Right.
the better the chances of preventing, further neurological damage.
Yeah, the source material mentions IV fluids, NEDs to manage blood pressure, even anticoagulants to prevent blood clots.
Yeah, all of those are important.
So it's a lot going on.
Yeah, it's a multifaceted approach to care. You're addressing both the immediate
Right.
and the long-term needs of the patient.
So let's talk about respiratory management specifically.
Okay, yeah.
What are some of the key interventions for people with SCIs?
So for injuries at or above that C5 level,
Right, those key muscles.
yeah, where those respiratory muscles are really affected, respiratory support becomes really important.
Okay.
You might need to intubate to secure the airway,
Okay.
mechanical ventilation to help them breathe,
Okay.
diaphragmatic pacing to stimulate that diaphragm,
Okay.
and then pulmonary rehabilitation to improve lung function and overall endurance.
Diaphragmatic pacing. That sounds interesting.
Yeah, it's pretty cool technology.
How does that work?
So they basically surgically implant electrodes into the diaphragm,
Okay.
and those electrodes deliver electrical impulses
Okay.
that stimulate the diaphragm to contract.
So it's like an artificial
Yeah, it's mimicking that natural breathing process.
boost. Exactly. Okay. And then what about pulmonary rehabilitation? What's that like?
So that's a comprehensive program that combines breathing exercises, techniques to clear those airways, physical therapy.
Okay.
So the goal is to strengthen those respiratory muscles,
Okay.
improve that lung function, and just, enhance their overall endurance.
That makes sense.
Yeah.
Okay. So shifting gears a bit, let's talk about another really serious
Okay.
neurological disorder.
Okay.
Amyotrophic lateral sclerosis,
ALS.
also known as Lou Gehrig's disease.
Right.
This is a progressive neurodegenerative disease, and it affects both upper and lower motor neurons.
Mm-hmm.
Can you explain what that means?
Yeah, so motor neurons, those are the nerve cells that control voluntary muscle movement.
Okay.
So think of them as like the messengers that carry signals from the brain to the muscles,
Okay.
telling them when to contract, when to relax.
Okay.
Upper motor neurons, they originate the brain,
Okay.
send signals down the spinal cord to the lower motor neurons,
Right.
which then directly connect to the muscles.
Got it.
So in ALS, both types of these motor neurons are affected.
Okay.
And that leads to, a range of symptoms, muscle weakness,
Okay.
twitching, and eventually paralysis.
Okay. And they say the cause is unknown,
Yeah, the exact cause is still unknown.
but they think genetic mutations might be involved.
Yeah, they think that plays a role.
And they say the incidence is about 5 per 100,000 with a survival time of 3 to 5 years.
Yeah, it's a tough one.
Yeah.
It's a disease that really attacks those cells that control our ability to move, to speak, to swallow,
Right.
even to breathe.
So speaking of breathing, how does ALS specifically affect the respiratory system.
So as the disease progresses, the muscles responsible for breathing,
Right.
including that diaphragm, they become weaker, less effective.
Okay.
So this can lead to shortness of breath, difficulty coughing, and
Okay.
eventually respiratory failure.
So it's not just the limbs, it's those muscles,
It's not just the limbs, no.
that we need to breathe.
Yeah, those vital muscles.
Yeah.
It's a really challenging aspect of this disease.
Yeah. One of the things they talk about is something called bulbar dysfunction.
Bulbar dysfunction, right. So that affects the muscles involved in speech, swallowing, chewing.
Wow.
Yeah. So as those muscles weaken,
So you can't even talk.
it becomes harder to form words, control saliva, safely swallow food and liquids. Yeah, and that can lead to drooling, choking,
Wow.
aspiration, which is when food or liquid enters the airways.
Okay. So how do they diagnose ALS?
So diagnosing ALS is often a process of elimination.
Okay.
They need to confirm the presence of both upper and lower motor neuron degeneration.
Okay.
They have to rule out other possible conditions that might be causing similar symptoms.
Right.
So doctors will typically perform a clinical exam,
Okay.
electrophysiological testing to assess nerve and muscle function.
Okay.
And sometimes they'll even do a neuropathological exam
Okay.
where they actually examine a tissue sample under a microscope.
Wow.
Yeah.
They mentioned some clinical signs here. Siluria?
Siluria, yeah, that's just a fancy word for excessive drooling,
Okay.
which can be common in ALS because of those weakened muscles in the mouth and throat.
Okay.
And then tongue fasciculation.
Okay.
That refers to those involuntary twitching or rippling movements of the tongue.
Oh, okay.
It's a sign of lower motor neuron involvement,
Okay.
which is, a key feature of ALS.
So they're looking at all those things to diagnose.
Yeah, they're putting all the pieces together.
Is there a cure?
Unfortunately, no, there's no cure for ALS currently.
Okay.
There is a medication called riluzole,
Okay.
which has been shown to modestly slow the progression of the disease.
Okay.
And it may extend survival by a few months.
Okay.
It's not a cure, but it's something.
It's something. Yeah. What about respiratory therapists?
Yeah, respiratory therapists are essential.
I mean, I imagine
They're on the front lines.
they're a big part of
helping these individuals manage those breathing difficulties.
the care.
Yeah. So they monitor lung function, teach breathing exercises,
Okay.
provide techniques to help clear those airways.
Okay.
And they also play a key role in deciding, when and if mechanical ventilation's needed.
Right.
So they're really helping to optimize
Quality of life.
quality of life, yeah, and ensure comfort as that disease progresses.
Yeah. It's a really important role.
It is. It's a very rewarding role, but also very challenging.
Yeah. So let's move on to another group of disorders that can have a big impact
Okay?
on breathing. Muscular dystrophies, MDs.
Muscular dystrophies.
Yeah, and these are genetic disorders.
Right.
And they're characterized by the progressive degeneration of muscle fiber.
Muscle fibers, yeah. And the thing about MDs is that they can manifest at different stages of life.
So not just,
You might see it in infancy, you might see it in adulthood.
one age group.
Yeah. And the severity can vary as well.
Oh, yeah.
Some forms are more severe than others.
Okay.
And some affect specific muscle groups more than others.
So it's kind of an umbrella term.
It's an umbrella term, yeah. There are many different types.
Can you give us some examples?
Yeah, so some of the most, well-known types include Duchenne muscular dystrophy,
Okay.
myotonic dystrophy, Emery-Dreifuss muscular dystrophy, limb-girdle muscular dystrophy,
Wow.
and facioscapulohumeral dystrophy.
That's a lot. How do they even diagnose all these different types?
So it often involves a combination of, a physical exam,
Okay.
looking at family history,
Okay.
seeing if there's any patterns of muscle disorders in the family,
Okay.
and then laboratory testing. Doctors might order tests to measure levels of certain enzymes like creatine kinase, aldolase,
Okay.
which are often elevated in people with MDs.
Okay.
And they might even do a muscle biopsy to examine muscle tissue under a microscope.
Okay.
So they're really looking at a lot of different factors
Yeah.
to try to make that diagnosis.
So what are some of the common clinical findings with MDs?
So, as you might expect, muscle weakness is a hallmark symptom,
Right.
often accompanied by fatigue and muscle wasting.
Okay.
Dysphagia, difficulty swallowing, can also occur.
Okay.
And importantly, respiratory muscle weakness
Right.
is a major concern in many forms of MD.
Right.
And this weakness can lead to, impaired cough,
Right.
difficulty clearing the airways,
Right.
and ultimately ventilatory failure.
So just like those other things we talked about, muscles we know to breathe
Breathing's affected.
are affected.
Yeah.
And unfortunately, is there a cure?
Unfortunately, no, there's no cure for MDs currently.
Okay.
But treatment focuses on managing those symptoms,
Okay.
improving quality of life, and slowing down that disease progression.
Okay. What kind of treatments are available?
So corticosteroids are often used to help slow that muscle degeneration,
Okay.
and other supportive therapies might be used to address the various complications that can
Okay.
arise from MDs, things like weight gain,
Okay.
behavioral abnormalities, excessive hair growth,
Wow.
diminished bone density, poor wound healing, impaired glucose control.
So it's a lot to manage.
It is. It is. It requires a team approach.
Yeah, it's not just one thing.
No.
They mentioned physical and occupational therapies.
Right. Those are key. Those are key for maintaining muscle function, mobility,
Right.
and, helping people adapt their daily activities.
Okay.
Yeah.
And they mentioned gene therapy.
Gene therapy, yeah, that's really exciting.
Yeah.
It holds a lot of promise for MDs. Researchers are exploring ways to replace
Okay.
or repair those faulty genes
Right.
that contribute to that muscle degeneration.
Right. So that's still in the works.
Yeah, it's still early stages, but there have been some really encouraging breakthroughs in recent years.
Wow. So that's something to keep an eye on.
Definitely keep an eye on that one.
So let's shift gears again.
Okay.
Talk about acute neurological events,
Okay.
specifically strokes.
Strokes, yeah.
So how can a stroke, which affects the brain, impact the respiratory system?
Yeah, so strokes can have a really big impact on breathing for a number of reasons.
Okay.
First, it's important to understand what a stroke is. It's an acute brain attack
Okay.
or a cerebrovascular accident.
Right.
And there's decreased blood flow to a part of the brain,
Okay.
either because of a blockage or a rupture in a blood vessel.
Right. And there are two main types, right?
Yes, there are two main types. We've got hemorrhagic strokes
Okay.
and ischemic strokes.
Okay.
So hemorrhagic strokes, that's when a blood vessel in the brain bursts.
Oh, wow.
And you get bleeding into that surrounding brain tissue.
Okay.
Ischemic strokes are caused by a blockage in a blood vessel,
Okay.
usually from a blood clot. And ischemic strokes are much more common.
Okay.
They account for about 80% of all strokes.
Yeah, they say approximately 800,000 strokes in the U.S. each year.
Wow.
And about 140,000 of those are fatal.
That's a huge number.
Yeah, and it's the fifth leading cause of death
Wow.
in the U.S.
It's a major public health issue for sure.
And billions of dollars in healthcare costs.
Absolutely. And understanding those risk factors
Yeah.
is so important for prevention.
So what are some of the things that increase your risk?
So hypertension, high blood pressure,
Okay.
that's a huge one.
Okay.
You've also got diabetes mellitus, tobacco use, elevated cholesterol,
Okay.
professional arterial disease, atrial fibrillation. Those are all major contributive.
So a lot of lifestyle stuff.
A lot of it is, lifestyle choices.
Yeah.
So making healthy choices, maintaining a healthy weight, exercising regularly, avoiding smoking.
Right.
Those can go a long way in reducing that risk.
Yeah. So let's talk about the clinical manifestations of stroke.
Okay.
Like, what are the symptoms?
So some people experience what are called transient ischemic attacks, TIAs,
Okay.
in the weeks or months leading up to a full-blown stroke.
What's a TIA?
So a TIA is basically a mini stroke.
Okay.
It causes temporary neurological symptoms that typically resolve within 24 hours.
Okay.
So it's often a warning sign
Okay.
that something is amiss
So you should see a doctor
and that a more serious stroke could be on the horizon.
if you have one of those.
Absolutely. Don't ignore those.
Okay. So besides a TIA, what else might you experience during a stroke?
So in addition to, neurological deficits, things like sensory, visual, cognitive impairments,
Okay.
people might experience facial and extremity muscle weakness.
Okay.
Their vital signs might be abnormal, increased blood pressure, decreased respiratory rate, fever.
They say the location of the stroke in the brain
Right.
determines the clinical presentation.
Yeah, it's like a map of the brain.
Right.
Different areas control different functions.
Right.
So the symptoms will vary depending on which area is affected.
Okay.
For instance, a stroke affecting the middle cerebral artery
Okay.
might cause sensory and motor impairments on the opposite side of the body,
Okay.
weakness in the lower face, difficulty speaking, visual disturbances.
So it's all connected.
Yeah, it's all connected.
Like different parts of the brain.
Yeah, a stroke
With
affecting
lots of different things.
the anterior cerebral artery
Okay.
might lead to motor impairment of the lower extremities, akinetic mutism,
Okay.
which is a lack of spontaneous movement in speech,
Okay.
and incontinence, and then a stroke affecting the posterior cerebral artery
Okay.
that can cause, a variety of symptoms, including paralysis on one side of the body,
Okay.
involuntary jerky movements, visual field deficits, memory problems,
Wow.
even visual hallucinations.
So how does all of this relate to breathing?
Right. So strokes can trigger a whole bunch of respiratory complications.
Okay.
You can have acute pulmonary edema,
Which is fluid.
which is fluid buildup in the lungs.
In the lungs. Okay.
Tachycardia, a rapid heart rate.
Okay.
Tachypnea, rapid breathing. Hypoxemia, low blood oxygen.
Okay.
Decreased level of consciousness. Impaired cough reflex.
Wow.
Inability to protect the airway. Aspiration pneumonia.
That's when you breathe in
Yeah, that's a lung infection
food.
caused by inhaling food or liquid. And then oropharyngeal dysphagia,
Okay.
which is difficulty swallowing.
So it's like a whole mess.
It can be, yeah. It can really affect the respiratory system in a lot of ways.
Yeah. And the breathing patterns can be messed up too, right?
Yeah, the breathing patterns could be quite abnormal.
Like what kind of patterns are we talking about?
So you might see obstructive or central sleep apnea,
Okay.
which are conditions where breathing repeatedly stops and starts during sleep.
Okay.
You might see Cheyne-Stokes respiration,
Okay.
which is a pattern of breathing with gradually increasing and then decreasing tidal volume,
Okay.
followed by periods of apnea.
Okay.
Um, Biot's respiration is another abnormal breathing pattern
Okay.
involving irregular respirations with periods of apnea.
Okay.
Apneistic breathing involves prolonged inspiratory gasps, followed by brief expiratory pauses.
Wow.
And then Kussmaul's respiration,
Okay.
that's characterized by deep, rapid breathing,
Okay.
often associated with hypoglycemia.
So it's like all sorts of
It can really...
we're breathing.
Yeah, there are a lot of different patterns.
So what do you diagnose as stroke?
So diagnosing a stroke is an emergency situation.
Right.
And interventions need to be started right away.
Okay.
You want to try to improve that cerebroischemia,
Which is that?
which is that lack of blood flow to the brain,
Blood flow.
and prevent further damage.
Right.
So CT scans, MRI, those are essential tools for visualizing the brain,
Okay.
identifying the type and location of the stroke.
Okay.
Supplemental oxygen might be provided to make sure they're getting enough oxygen.
Okay.
And intracranial pressure monitoring might be necessary in some cases.
Okay. So what about specific treatments?
So for ischemic strokes, a medication called tissue plasminogen activator, or TPA,
Okay.
might be used to try to dissolve that blood clot
Okay.
and restore blood flow.
Okay.
But TPA, it can only be given within a certain time window,
Okay.
typically 4.5 hours after the onset of symptoms,
Oh, wow.
and only if certain criteria are met.
Okay.
In some cases, a procedure might be performed
Okay.
to actually mechanically remove the blood clot.
Oh, wow.
And then antiplatelet therapies, like aspirin and clopidogrel,
Okay.
might be given to prevent further clot formation.
Okay. What about supportive care?
So supportive care is also crucial.
Okay.
This might include antipyretics to reduce fever,
Okay.
cooling blankets to manage body temperature.
Okay.
If a patient's Glasgow Coma Scale score, which is a measure of consciousness,
Right.
is below 8,
Okay.
there's concern for airway protection, and they might need to be intubated.
Okay.
Preventing hypoxia and hypercapnia, that's essential because those conditions can increase intracranial pressure and worsen brain injury. And it's important to avoid those actions that trigger cough and gag reflexes in the acute phase because those can be detrimental.
Okay, that makes sense. So what about respiratory therapists?
Yeah, respiratory therapists are key members of that stroke care team.
I imagine they are.
So they're providing those bronchial hygiene techniques, clearing the airways of secretions,
Right.
encouraging early ambulation, getting people walking to prevent those complications.
Right.
And they administer medications like atropine and Botox to manage secretions and muscle spasticity.
Okay.
They provide non-invasive ventilation if needed.
Okay.
And in some cases, they might even recommend a tracheostomy
Okay.
for long-term airway management.
So they're pretty involved.
Yeah, they're really involved in all aspects of respiratory care for these patients.
That makes sense. Okay, so we've covered strokes. Let's move on to our last topic, head injuries and traumatic brain injuries, TBIs.
TBIs, yeah. A major cause of death and disability. In the U.S., they contribute to 30% of all deaths.
Wow.
And like strokes, TBIs can have a significant impact on the respiratory system.
In what ways?
So, decreased consciousness following a TBI increases the risk of aspiration, where you get food or liquid or even vomit entering the airways.
Right.
And it can lead to apnea, cessation of breathing, airway obstruction, hypoxemia, hypercapnia, decreased oxygen delivery to the brain.
Okay.
And that can have, really bad consequences.
Yeah, so it sounds like protecting the airway is super important.
It's paramount, yeah. You need a thorough assessment to identify any maxillofacial or spinal cord trauma.
Okay.
And protecting against hypoxemia, cardiac arrest, hypocapnia, hemodynamic invisibility. Those are all top priorities.
So what are some ways that you protect the airway in these cases?
So the jaw thrust maneuver, that's a technique for opening the airway without tilting the head back,
Okay.
which is important if you suspect a spinal cord injury.
Got it.
And then supraglottic airways.
Okay.
Those are devices that are inserted into the mouth to maintain an open airway.
Okay.
Those might be necessary as well.
The source material mentions fluid resuscitation, awake intubation, early tracheostomy, continuous ICP monitoring. Can you just break down what all of that means?
Yeah, so fluid resuscitation, that's using packed red blood cells and IV fluids to maintain blood volume and blood pressure.
Okay.
Awake intubation, that's when they keep the patient conscious during the intubation process
Okay.
to secure the airway.
Okay.
Early tracheostomy might be considered for long-term ventilation.
Okay.
And then continuous monitoring of intracranial pressure, that's just to make sure the pressure within the skull is staying within a safe range.
And respiratory therapists are involved in all this too, right?
Oh, absolutely. They provide oxygen therapy, airway clearance techniques,
Okay.
bronchodilators, lung expansion therapies, mechanical ventilation if needed,
Okay.
early mobility through physical therapy,
Okay.
and even tracheostomy care for those who need prolonged airway support.
So they're really involved in every step.
They are. They're vital members of that TBI care team.
Wow, we covered so much in this deep dive. Guillain-Barré syndrome, myasthenia gravis, spinal cord injuries, ALS, muscular dystrophies, strokes, traumatic brain injuries. It's incredible how something going wrong in your nervous system can have such a huge impact on your ability to breathe.
It is, and it really underscores how interconnected all the systems in our body are.
Absolutely. And respiratory therapists, wow, they play a vital role.
They really do. They're unsung heroes on the front lines of neuro-respiratory care.
Yeah, so I want to thank you so much for coming on and sharing all this information with us. This is a fascinating topic, and I hope everybody out there learned a lot about it.
It's been my pleasure. Thanks for having me.
And to our listener who requested this deep dive, we hope this information has been helpful. And if you're a healthcare professional working with these conditions or just someone who's curious about the human body, we encourage you to keep exploring because it's a fascinating area of medicine. Thanks for listening.